So as I mentioned, I'm going to try and discuss targeted therapy and perioperative therapy afterwards. These are my disclosures or declaration of interests. First of all, to discuss a little bit about targeted therapy for non-small cell lung cancer. So these are the current ESMO clinical practice guidelines for metastatic oncogene-addicted non-small cell lung cancer. And I think these are pretty clearly laid out guidelines and pretty practically useful as well. You'll see here on the left of the screen for EGFR-mutant lung cancer, the level 1 evidence supports osimertinib. However, there are other options for drugs, including gefitinib, erlotinib, afatinib, and dacomitinib. For ALK-translocated lung cancer, the most commonly used agent, at least at this time back in 2023, was alectinib. However, obviously, brigatinib, lorlatinib are also good options in that setting. ROS1, we're talking about primarily entrectinib and repotrectinib at this point. However, waiting potentially for further approvals in this space. BRAF V600 has not changed a whole lot. Dabrafenib, trametinib. RET translocated disease. Outside of North America at the moment, selpercatinib is the main agent available. Pralsetinib is not being pursued, at least for regulatory approval outside of North America. And for these rarer alterations, so NTRK, for example, we do have larotrectinib, which is approved in the United States, and entrectinib may be an option. And for MET exon 14, capmatinib and tepotinib. And finally, we have a couple of second-line agents. So KRAS G12C mutant disease with adagrasib and sotorasib, and HER2 mutant disease where we have trastuzumab deruxtecan. So a much more complicated setting now compared to, say, 5 or 10 years ago. Focusing in on EGFR mutant disease, you will likely have seen these data previously from the FLAURA trial, which compared the third-generation tyrosine kinase inhibitor osimertinib to the previous generation agents, gefitinib or erlotinib, showed initially a significant improvement in progression-free survival, hazard ratio of 0.46, favoring osimertinib, with an absolute median difference of about 9 months between the two treatment options. You will see more benefit potentially on an exon 19 disease here, hazard ratio 0.43, however, also highly significant in exon 21. Here you'll see for overall survival, again, a significant benefit. And this isn't very common in EGFR mutant lung cancer to actually show an overall survival benefit, which we did see in this trial. So before 2024, this was what the landscape looked like, at least in the West, with osimertinib being by far the most commonly used agent. However, several other agents, either in development from anything from phase 1 to phase 3 disease, with drugs like furmonertinib, lazertinib, amivantamab-Lazertinib, all delivering, however, a median PFS in the region of 19 months, and a better prognosis overall with these kinase inhibitors for exon 19 disease as opposed to exon 21. Then, however, we first had the FLAURA-2 study, and this looked at kind of an old strategy here, intensifying therapy with chemo, adding chemotherapy to osimertinib in the first-line setting compared to osimertinib alone. And this was carboplatin pemetrexed. Here, the primary endpoint of the study was progression-free survival, with secondary endpoints of overall survival and other efficacy outcomes. And as you might expect, when you intensify therapy, you do see improved progression-free survival, whether it be by the investigator assessment, with about a 9-month difference favoring chemotherapy plus osimertinib, or by blinded independent review with about a 10-month difference. But overall, both favored chemo osimertinib. But this is progression-free survival. And one question arises, are you just giving all your good therapies up front? And will you truly see an overall survival difference? What patients might be the ones we would consider this treatment for before we have overall survival data? Well, it appears that patients, for example, with brain metastasis, CNS disease, derive quite a lot of benefit here from the addition of chemotherapy. And this is a little bit counterintuitive because we don't necessarily think of chemo crossing the blood-brain barrier. Pemetrexed does to a degree, but this is also probably a surrogate for poor risk disease where more intensive therapy might benefit the patient more. And then, so if we look at those patients with probably the poorest prognosis, so those patients with exon 21 alterations and those with brain metastasis, we do see significant benefits here in terms of progression-free survival, with the curve separating pretty early, around 3 to 4 months, and staying separated throughout the follow-up period. And the other question is, can you actually impact the outcome from brain metastasis by adding chemotherapy? Now, these are relatively small groups, about 38 patients in each group, chemo, osimertinib, or osimertinib alone. But you see the complete response rate in the brain going from just 16% with osimertinib alone to 48% with chemo osimertinib. So if there's a group of patients for whom I would consider chemo osimertinib up front, or at least discuss it with them, I would think of patients with relatively high volume brain metastasis. In terms of overall survival, well, we're still waiting at this point. It's not yet mature. The last follow-up was in last year, with overall maturity being at about 41%. A trend perhaps towards favoring chemo osimertinib, but further follow-up needed. And the curves did cross early here, so probably not proportional hazards so far, at least in the follow-up for OS. So if you were to ask me this question last year or the year before, what is the appropriate therapy? I would still say probably osimertinib is the standard of care. There may be select patients, perhaps those with brain metastasis, or those with L858R mutations, for whom one could consider the addition of chemotherapy up front. However, we also have Mariposa, and this was a study comparing so Amivantamab plus Lazertinib, which is a similar TKI to osimertinib, or versus osimertinib. So that's the primary comparison here. And also including a third arm of Lazertinib, mainly to differentiate contribution of components. Primary endpoint of this study, again, was PFS. These are the demographics of the patients, so relatively representative of the lung cancer patient population with EGFR mutant, about 60% from Asia, about 40% of patients having brain metastasis. And we now have significant overall survival benefit from this study. So patients who got Amivantamab-Lazertinib have not yet reached the median overall survival, and osimertinib is performing about what you might expect, 36.7-month median survival, with a significant hazard ratio of 0.75 favoring Amivantamab-Lazertinib. One issue here, though, and particularly with this thing which was put on the slide about a projected 1-year median overall survival benefit, the curves do cross early here. So there are not proportional hazards here. So I don't think we can necessarily make this assumption, which was noted in the presentation. However, the study is positive for overall survival, and I think should have an impact on treatment. Which patients might benefit more from this treatment? Well, you'll see here again, higher risk disease potentially, those patients with brain metastasis, significant hazard ratio 0.67. Potentially also those patients who are younger, fitter, and potentially can tolerate more treatment, hazard ratio of 0.53. But not quite as clear-cut in terms of selecting out patients here for treatment from Mariposa. What is my current approach? So I discussed with patients that Amivantamab-Lazertinib can offer a potential improvement in overall survival. It should be noted there was very little crossover in the osimertinib arm to Amivantamab. So would you derive as much benefit from giving osimertinib up front and then potentially treating with Amivantamab later? That's not answered. But there is a cost as well with Amivantamab-Lazertinib of significant time. So at least with the intravenous version of Amivantamab, and physical toxicity, quite significant skin toxicity for some patients, and also some diarrhea. With chemo osimertinib, there's a PFS benefit, but no overall survival benefit at this point. I would still consider it potentially for patients with brain metastasis. And what patient would I definitely favor osimertinib monotherapy? I think lower risk patients with more indolent disease, and those patients who are more frail. I would tend to reserve combination regimens for higher risk disease at this point until we have longer follow-up and perhaps more studies. In terms of other alterations, I think this is a nice scale that ESMO has looking at actionability, and you'll see right here at the top, EGFR, ALK, ROS1, RET. There are several other alterations which I won't go into in too much detail today, but MET, BRAF, ROS1, they're further down the scale. And then even lower again are things which are only really actionable second line at this point, like KRAS G12C, HER2, and potentially MET amplifications. One of the characteristics of these patients, and this is courtesy of Jordi Rahman, who's an expert in targeted therapy, you'll see there are significant differences here. For example, BRAF V600 is not the same as EGFR mutant disease. The majority of patients with BRAF V600 have a history of smoking, for example. You'll also see KRAS G12C, as we know, has a high incidence of smoking, MET amplification, high incidence of smoking. So not all of these are the same. So when we talk about oncogene-driven or actionable genomic alteration lung cancer, this is quite a heterogeneous group of patients. But what are the common things between these different oncogene fusions in particular? So they have a high risk of brain metastasis. They often have a high risk of thromboembolic events, particularly things like RET fusions, ALK fusions, ROS1 fusions. It's important to be aware of drug-drug interactions. So, for example, if a patient has a blood clot and we have to add a DOAC, some of those will interact with the current treatments we use for these. And we can often see what's called pseudo elevation of creatinine, and this is caused by MATE1 inhibition. So we should interpret with caution kidney function when patients are on these tyrosine kinase inhibitors. Specifically talking about ALK fusions, so the major advances over the last several years have been with alectinib. So we'll see here in the ALEX study a dramatic increase in progression-free survival with alectinib compared to crizotinib, hazard ratio 0.43 favoring alectinib over crizotinib. And this was driven to a large extent by the increased CNS activity of alectinib, with a hazard ratio favoring alectinib of 0.37. And overall survival, while not statistically significant, also favored alectinib. With brigatinib here, we see a very similar data set and also an impact on brain metastasis. Again, hazard ratio 0.25. Most recently, and we've had the CROWN data with lorlatinib presented at ASCO last year and published shortly afterwards. And perhaps this is the first time we're seeing lung cancer being turned into a chronic disease, with a median progression-free survival for patients treated with lorlatinib in the first-line setting, which exceeds 5 years. However, toxicity profile does matter. So I wouldn't say necessarily between alectinib and brigatinib, one is more toxic or less toxic, but the toxicities differ. With alectinib, we see constipation, fatigue, anemia being quite common, whereas with brigatinib, we see more so GI upset, nausea, dyspnea, headache, some arthralgias. Lorlatinib, I think the predominant side effects which we worry about with it are hypercholesterolemia, which has to be managed, but also neurologic events such as peripheral neuropathy, cognitive slowing, and dizziness can also be a side effect. So for younger patients in particular, lorlatinib can be quite hard to manage. In terms of the grading, I think it's quite important that we do this in terms of assessing what types of side effects our patients have, because this can help determine whether we need a dose reduction, a dose interruption, or even a cessation of treatment. The ALK variant also matters. So for example, in the CROWN study, when you look at ALK variant 1 versus 3, you'll see a quite significant difference in outcome here on the left of your screen. However, can we use it to actually select patients in the frontline setting? And it's not entirely clear this is the case. There's a low number of patients in these where we know which variant was present. It doesn't necessarily look across these trials because of the small number of patients, whether we can select one agent versus another. But I think it's an interesting area and one which will probably become more relevant as more ALK TKIs become approved. And there are new TKIs on the horizon. We saw presented at ESMO last year data with Nuvalent 665 in the ALCO-1 trial. And this is an ALK selective TRK sparing. So the idea here is that you avoid some of those neurologic adverse events which you see with lorlatinib. And this looks to be an active TKI, probably at least as active as lorlatinib, and with relatively low rate of neurologic events, albeit with a small number of patients enrolled as yet. So I think this is something to watch in this space. We've also seen these agents move to the adjuvant setting with the ALINA trial, where we have a positive study now for disease-free survival, fairly dramatically positive, hazard ratio 0.24, and most of the impact here being in the brain, as you might expect. There's also a study called Horizon 01, which is testing alectinib in stage 3 disease, post-chemo radiation. In the United States in particular, there's been something of an adoption of this in the absence of trial data. However, I think ultimately Horizon 01 hopefully will provide a framework for actually using this in clinical practice.